Good morning, everyone. Thank you for being here. Today, it's my distinct honor to introduce Dr. Claire Creutzfeldt, a prominent figure in the field of neuropalliative care and vascular neurology, as our guest speaker for the Grand Rounds talk. Dr. Creutzfeldt earned her medical degree from Ludwig Maximilian University in Munich, Germany, and she completed a neurology residency, vascular neurology fellowship, and as well as a postgraduate training in palliative care from University of Washington, where she is currently an assistant professor and a clinical researcher. Dr. Creutzfeldt's research focuses on integrating palliative care into the emergent and ongoing care of patients with severe acute brain injuries and their families, including people affected by stroke, TBIs, and post-cardiac arrest. Dr. Creutzfeldt has co-edited and authored several books, including a textbook on neuropalliative care with Drs. Klugler and Dr. Holloway. And she has authored several peer-reviewed manuscripts with focus on neuropalliative care, communication and decision-making for people facing severe neurologic illnesses. She has continuously been funded by Cambia Health Foundation, National Institute of Neurologic Disease and Stroke, as well as National Institute of Nursing Research. Today, we're delighted to have Dr. Creutzfeldt here as our guest, all the way across from the West Coast, which is pretty early there, sharing her profound insights into the important topic of neuropalliative care. Dr. Creutzfeldt, thank you for giving us this lecture. You can proceed.
Thank you. Thanks, Johannes. And thanks all for having me. Yeah, I'm just trying to have my eyes wide open for this talk. I will share my presentation. It's actually interesting. I'm actually older than it might look because I'm an associate professor, but somehow Google still suggests in most places that I'm assistant. But anyway, other than that, thank you for your wonderful introduction. So what I want to talk about today is how we as neurologists should want to integrate neuropalliative care into our practice. And I have some funding, but no real disclosures. So what I want to do today is I will start by sort of setting the stage and talking a little bit about the neurological illnesses that I'm particularly interested in, stroke and severe acute brain injury. Then I'll go a little bit into palliative care, review some evidence and make a case for neuropalliative care. And then I go into what really interests me, communication in neuropalliative care and how we integrate it. And I'll sort of bring my research into all of those a little bit. So severe acute brain injury comprises those illnesses that leave a patient acutely neurologically devastated. And the main players are stroke, TBI, and cardiac arrest. Together, they account for 12 million deaths annually worldwide and are a leading cause of disability. So the challenges for patients, providers, and healthcare systems are evident. I also, of course, want to acknowledge the flabbergasting progress that has been made in actually both in palliative care and in neurology. But if we just think about, the innumerable and often impronounceable medications we have for MS now, dementia, muscular dystrophy, people live much longer now with those. And for stroke, of course, we're now actually curing people if they come to the right place at the right time with the right kind of stroke. And so this progress, I always feel, has led to something else that requires our collaborative attention. And that is that patients and their families are faced with a proliferation of available choices. So in the hyperacute setting of stroke, would you want to be intubated, or would you want to undergo a decompressive hemicraniectomy? How about a PEG or tracheostomy a little later? And so the cost of being ill-equipped to choose is greater now than ever. And so when I think about integrating palliative care into any illness, I like to think about how the illness trajectory works. So what I mean is that, so what you see is you see the function from low to high, and time from diagnosis to death. That's how an illness sort of presents itself. And so what we think of the classic kind of palliative care illness is cancer. And these patients will present when they're still functioning quite high. They will be diagnosed. They will have, hopefully, conversations and thoughts about their values, how they want to be treated, how aggressive they want medical care to be, and also what their end-of-life wishes might be. And then the decline is actually relatively short at the end, the decline to death. Another illness trajectory that has sort of really found its way into palliative care is the one of chronic illness with exacerbation, so COPD and heart failure. I guess in neurology, we could think about MS, I think would be the best example for that one. So people also tend to be diagnosed when they're still functioning quite well. And then they have usually sort of a very slow decline with some exacerbations. And each of those exacerbations may be an opportunity to revisit goals and treatment values and end-of-life wishes. And then one of these attacks will eventually lead to death. Third trajectory is that of prolonged dwindling, and so movement disorders and dementia are often mentioned, and I'd like to say that it's aging, because we all have that. And I think that suggests sort of that that's actually really hard to know when it's time to consider your values and to revisit them, and to at some point also consider your end-of-life wishes. The trajectory that we're talking about today is totally different, because the people who present with severe acute brain injury actually present to us at their worst. We meet them at their worst, and you all know what happens where the red arrow is. We meet them at their worst, and we make decisions, many of which will lead to an early death. And so I like to think that we often only get one opportunity to get a life-changing conversation right. And of course, these loaded conversations cover immense ground. Bad news, emotion, prognosis, treatment choices, and patient goals all play a part in coming up with the right plan for each individual patient. So within that, what do I need to know about you as a person to give you the best care possible? So let's think a little bit about palliative care and the evidence. I know that you all know what palliative care is, but just to be on the same page, palliative care is medical care that focuses on improving communication about goals of care, and maximizing comfort and quality of life. I think it's important. Actually, I was just talking to our neighbors yesterday, so I think in the lay public, it is still considered the same as end-of-life care, but actually end-of-life care is only a very small part of it, and that is the care for those who are actively dying. And so I think that's sort of that progress that palliative care has made, is that maximizing quality of life is maximizing comfort and quality of life is probably not only our goal when we're dying, and living better with a serious illness is probably a good goal from the beginning of that serious illness. And so there have been many studies, and I'm showing you this one, which was a nice meta-analysis of randomized controlled trials of palliative care interventions for serious illness. So this group of researchers actually at Pitt looked for randomized control trials that had a palliative care intervention that they actually defined pretty nicely as, so very broadly. A palliative care intervention was an intervention that was consistent with the philosophy or components of palliative care, including interventions that may not be explicitly described as palliative care. So the interventions actually ranged from having palliative care specialists involved with patients to having a nurse call patients on a regular basis, inpatient, outpatient, and so on. And so they found, and of course their goal then was to see, how does that affect outcome? They ended up reviewing 43 articles, and the general result of this is that palliative care is beneficial, and it improves quality of life for many, and I think this meta-analysis, along with all the studies that had been done before, has been a big milestone to show that palliative care is good for people with serious illness. Although, of course, I'm not telling you all the details about it. I should actually mention that 70% of the trials included patients with cancer, another 14% patients with heart failure, and of course, really no patient with neurological illness. And I put this black box around the palliative care intervention because, of course, these were very varied interventions. I think, now I put up those 70%, I think. One of the oldest studies that is included in that is, I think, one that sort of started my career, which was Jennifer Temmel's study that was published in 2010, where they, in retrospect, simply took people with advanced lung cancer and randomized them to meeting with a palliative care team versus usual care. And they were able to show this beautiful finding that not only did the intervention group have higher quality of life and lower depression and anxiety scores, they also seemed to live longer. And so this group actually got together with Tony Bach and sort of asked themselves, what's in the syringe? What were those palliative care specialists doing that led to all of that? And so what they did was they took from the intervention group, they took the palliative care consultation notes and read them and did a qualitative analysis and identified 7 key themes of what was sort of in that syringe. And they came up with relationship and rapport building. The palliative care specialists addressed symptoms, they addressed coping, they engaged family, they helped with illness understanding, they also discussed cancer treatments and talked about end-of-life planning. So, of course, now we want to think about, that was cancer, what is there for non-cancer diseases? So actually, Dio Cavallaratos went along with another group and they said, let's look for something similar in non-cancer diseases. And I think about a third in this meta-analysis had heart failure. And then another half of those RCTs had sort of mixed disease. And I think there was a wee bit of stroke and in there, and 1/10 had dementia, but still not really neuro. And they showed no difference in quality of life in the intervention group. This was published in 2020. And then Benzi Kluger came along and did a randomized control trial in I think the first sort of randomized control trial for palliative care intervention in neurological diseases. And he randomized patients with Parkinson's disease and their family members, identified them through a pretty extensive checklist as having palliative care needs, and then they were randomized to meeting with a multidisciplinary palliative care outpatient team. I think they had an average time at the clinic of about 2.5 hours, where they would meet with social workers, chaplain, I think maybe a physical therapist also, and usually a neurologist with palliative care training. And their results actually were that the intervention group sort of seemed promising until you read or look at the real details. So the results were that the patient quality of life in the intervention group, as you can see here, I think you can see my arrow. So in their primary outcome was patient quality of life at 6 months. And this is wrongly printed by JAMA. This is caregiver burden. So the Zarit burden index, also at 6 months. And so they were able to show that patient quality of life at 6 months was significantly better in the intervention group compared to the control group. Although if you look, you're going to see, I think the QoL-AD, the quality of life for Alzheimer's disease scale, goes until 52. And we only have 30 to 38 here. And the difference, there is no, I don't think there's a published clinically important difference. But it's sort of, you sort of ask yourself, how big is the difference for that investment? And similarly, there was no significant difference in the caregiver burden scale at 6 months, but there did seem to be one at a year and going on. Although again, the Zarit goes from 0 to 88, with a lower scale being better. And Zarit's scale of 24 is actually considered severe burden. And so again, we don't know what the minimal clinically important difference is, but we can see that the difference is small, promising but still. So this was also published in 2020. And then in the UK, they did another randomized control trial where they took patients with long-term neurological conditions. These were vast majority, I think 70% also had multiple sclerosis, and randomized them after their hospitalization. I think they were randomized to a palliative care team who also did assessments, palliative care needs assessments, helped family members, and they their primary outcome was what I think that group developed, the integrated palliative outcome scale, which is mostly symptoms based, but they also looked at quality of life and depression and found no difference. So this is the integrated palliative outcome scale. So there was no difference. There was also no difference in the secondary outcomes. And so I thought you could refill your coffee as you think about what this means. So why do we think these studies weren't overwhelming? And we can think about that it's really hard to measure these palliative care interventions when they are all such different types of interventions. They had different measures. So I'm not just talking about the neuro ones, I'm actually also talking a lot about these meta-analyses of the non-neuro patients, different outcomes. Then what's sort of funny is that they were all published in 2020, and this is a picture of my daughter at Halloween in a very scary costume. So that's of course maybe one. And of course we neurologists will also say, neurology has just got to be a bit different. And I hope you all know the awkward Yeti, because I love those heart and brain cartoons. Anyway, this one is heart running up to brain and saying, I have to tell you about my crazy dream last night. And brain says, let me stop you right there. Nobody wants to hear your dream. I mean, never. Your weird dream is only interesting to you. Besides, You don't even dream. You just pump blood. And then heart actually wakes up from its dream. But I'm on brain side, it's just a bit different. I hope you recognize this painting. This is drawing. It's by Jean-Martin Charcot, 1880s or so, considered the father of modern neurology, and describing a patient with PSP. To show that there are probably some neurospecific palliative care needs that are probably obvious to all of you, but lots of people have written about them, and some are more obvious, some are less. So cognitive, communication, behavioral issues are huge, of course, with patients with neurological illness, and can lead to high caregiver burden. I find this idea of the disease being intrinsic to the person a fascinating one. This idea that cancer, for example, is extrinsic, and it came into my body and I am fighting it now. It's sort of the evil thing that I'm fighting, while the neurological disease is me, and I am clumsy now, and I am forgetful. And so that's sort of the more intrinsic part, which I think just presents its additional challenges. The caregiver burden, personhood. I think many of us will agree that the brain is clearly involved with who we are. And so if the brain is diseased, then that changes and that is threatened. So that is huge in neurology. I'm not saying that doesn't happen in other illnesses. You may have read Paul Kalanithi's book, When Breath Becomes Air, where he beautifully describes his journey with lung cancer. And one of the first things he actually writes about is that diagnosis completely changed his person. But of course, I think there's something different when it's that intrinsic disease that does that. And then prognosis, something we all struggle with and are also fascinated by, but the uncertain prognosis in many of our neurological illnesses is a huge challenge for clinicians, patients, and families. So you remember what I was talking about with what's in the palliative care syringe. Len Tran was a medical student who wanted to do a summer project with me. And so he spent the entire summer thinking about what is in the palliative care syringe if we think about patients with severe acute brain injury. And so this was not a randomized trial. These were simply palliative care consultations that were, as in most people's practice, I think, sort of almost randomly called on our neuro-ICU patients. And so we collected all the palliative care consultation notes in the neuro-ICU over, I think, a year. Again, did an analysis of the notes to try and find out what are palliative care consultants even doing in the neuro-ICU. And the 4 key themes that came out of it was prognosis. They talk about prognosis. They try and elicit patient values. They help interpret medical information. And then conflict was a big one as well. Conflict among family members, conflict between family and clinicians, and even between different clinicians. And then Rachel was actually a medical student at the time at Vanderbilt, and was able to spend 6 months with me, and then also became a resident with us and stroke fellow. She joined our group as we were interviewing physicians, nurses, and patients' families in the neuro-ICU. The picture here is actually taken out of a neuro-ICU patient's room, where a family member put this rock in the window, which I thought was so beautiful, that says hope. And then you can see Elliott Bay out there, and the Smith Tower, which apparently was the highest building west of the Mississippi in the 70s. Of course, there are now many others. So as we were interviewing clinicians and families about sort of palliative care needs and support needs of patients and families in the neuro ICU, two themes emerged here. Is there hope? And is she there? And I think these are fundamental needs in the neuro ICU, and I will challenge you all to think of a recent patient where you could have answered either of those questions with a simple yes or no. And then more recently, we interviewed another set of family members of patients with severe acute brain injury. And I'll actually talk about that study in a little more detail later. But one question that we asked towards the end of the interview was, what is the worst part of this for you? So these are family members, average day, mean day, hospital day 5. And we asked them, what is the worst part here? And the overwhelming answer was, the toughest part is the unknowns, being uncertain about, the future. The worst part is the not knowing. The unknowns of, I think we started with the unknown of whether she would live. And I think we're at least feeling like we're on the tail end of that, to where now we can start thinking about what a recovery might be. And then just to keep the story of severe acute brain injury, a group around Chris Cox did a nice study in their ICUs, and they measured lots of things, but also measured hospital anxiety and depression scale at 6 months in ICU family members. And this figure shows the distinction between the surrogates of patients with severe acute brain injury and those with not severe acute brain injury, with general critical illness, as I would call it. And so their HADs at enrollment and during the hospital stay is actually similar. So their distress, their psychological distress, but as the non-SABI group goes sort of down on their distress experience, the surrogates of patients with severe acute brain injury stay pretty solid with high psychological distress. I'm sort of hearing something. If anyone has a question, I'm happy to talk about it now, or otherwise I'm going to, yeah, I think I'm just going to go into my next section. So thinking about communication in neuropalliative care, which is obviously a big one. And I think there are so many things we can say about communication. I think we all know that everything, or the effect of everything we say, always depends on how we say it. Some people say that communication is at the heart of every problem and at the heart of every solution. I love how Atul Gawande actually talked about communication being a procedure or a skill, just like a surgical procedure. And he actually, in his book Better, he talks about this amazing privilege that we all have, especially as trainees, that we can practice what we do on a real person. And so whether it is a surgery or a serious illness conversation, at some point, we're all practicing. That privilege is only possible because we work as a team. We're not going to send a medical student or resident in on their own to operate on someone. We do, unfortunately, actually do that with communication, and that's one big thing that I think we need to change. we work as a team, and we need to be there as a team and practice our communication so we can get better. And when I say team, I'm not just saying the resident and the attending team. I have a lovely story that I experienced that showed to me how important the team is that we have in our hospitals. It was a patient who had a severe stroke. I think it was an intraparenchymal hemorrhage, and he was herniating, and it was pretty obvious that he was moving towards death. We had done our first brain death examination and I don't remember the details, we weren't able to do the full exam, and so I ordered a nuclear scan and was unaware that this was, and I was unaware that it would happen so quickly. And so it happened a little too soon after he had fully herniated. And so there was still a little bit of perfusion visible. And so here I was having to walk into the patient's room and tell his wife that our studies had suggested that he was dead, but not quite, that kind of. And I was stumbling a little, and was fortunate that the chaplain actually was already in the room and had already been talking to this wife, and she interrupted me, and she turned to the wife and said, "I think what Dr. Creutzfeldt is trying to say is that he's on his way." And that was something that was so effective and beautiful, not something that I could have said or would have said, but what had to be said. And so just sort of an example that we're a team. I want to tell you another story. This is a patient not too long ago, Maria. She was 46 when she collapsed during a violin performance. She was intubated on the scene. She was comatose on arrival, had very small pupils, and her head CT showed this large pontine hemorrhage. So she was admitted to the neuro ICU, and we worked on her blood pressure. And so the next morning I met with her husband and her brother, and they wanted to know what those families want to know, which was, what are her chances? And we wanted to know, what are her goals and values, or what might they be? And so I will start actually with the second question and then go a little bit more into that first question. I think one of the questions we have taught people to ask is, what would she want? And there's actually a beautiful paper describing that is not the right question to ask. And so next time you ask that, try to say it differently, and I'll get into that. But why is what would she want not the right question? Well, the first reason is that it focuses the values on treatment versus goals. So, what would she want? Well, a PEG tube, rather than thinking about sort of a big picture and what is most important to her. The second argument is the question can actually shut down conversation, because once they've said they want a PEG, or she would want a PEG, the conversation is kind of over. And the third one, which explains the unicorn in the corner, is that want is aspirational and evokes fantasies. So just like you can ask a child what they would want to be when they grow up, it suggests that anything is possible. And so what we tend to teach is that maybe just a slight change in language would be, what would she say? If she could sit here with us, what would she think about all of this? Anyway, that's sort of that, the idea about want. And then the reason we ask about what is most important to your loved one is because we're hoping to achieve goal concordance. So we want to identify what treatments are appropriate for this individual, given their prognosis and their goals. So a few things that I've written about. One of them is that is this idea of the future self, or some people call it affective forecasting. So how can anyone predict how I will feel about something in the future? Especially after I've adapted maybe to a different health state. And I think that's a really important issue, at least to bring up, maybe to know for ourselves, but also to bring up with families, that it's hard to know how someone will actually be able to adapt. In this paper, we asked patients' families in the neuro ICU again, what type of medical care their loved one would want. And we asked, was it medical care focused on longevity, on living as long as possible, even if that might increase suffering, versus medical care that focus only on comfort, even if that might limit the length of life. And I think we had an I don't know. So we asked what their loved one, I think we asked what they would want, and also what they were receiving. And then when that didn't correlate, we called that goal discordant care. And we actually found goal discordance on, as I said, a mean of hospital day 5 in 35% of our patients, and made an argument that that is probably okay. So how much goal discordance should be acceptable, especially in intensive care unit? And one of the reasons we made the argument that it may actually be okay is because of the way that the families answer this question for us. They would often say, and they would tick the box for comfort and say, he would really want to focus on comfort, but right now we're still trying to keep him alive. So sort of this temporary idea. And so when and how much of goal concordance is okay. And then this was a paper where we asked those same family members, we asked them where they think their loved one would draw the line. So what level of 6-month cognitive and functional disability would be acceptable to them? And we had sort of a range of 5 different scenarios, from not awake and not conscious to normal, and asked families to draw the line. And then at 6 months, we selected those survivors who had not reached that, what some people would call minimally acceptable outcome. And so patients who had recovered to a state that was less than what the families had considered. And so we wanted to explore sort of their adaptation and their quality of life, and how they, I think we wanted to go a little bit into regret, although didn't really get there. But it was this adapting that was fascinating. And one of the things we sort of developed from this was this model where we thought about, you have the severe acute brain injury, and then you have patient and family long-term outcomes. And, what can we do actually to improve those? And what happens, the process that happens over these several months after the severe acute brain injury include adaptation to some kind of a new health state and ongoing decision-making. What was, again, quite impressive was how uncertainty seemed to be in the way of that. It helped people, it fostered hope, it drove ongoing decision-making. And we're talking 6 months, we're even some people talking 9, 10, 11 months, who were still hoping for a huge step in recovery at the time. And so the feeling also was that uncertainty that probably wasn't always justified anymore at that time, seemed to hinder their ability to adapt to a new normal, as they were still hoping for better. So that was my actually little excursion into the what would she want. But the other question is, what are her chances? You know, what's her prognosis? And it brings me to my favorite current book that I'm working through for the second time, thanks to you. And what Phil Tetlock here is doing is he's thinking about the act of really predicting. And what Phil Tetlock did is he found a group of lay people who just predict highly accurately, and he describes their success in this. His group of super forecasters actually went into competitions with CIA to predict important political events. You know, will China invade Taiwan before the end of the year? This huge question of, is that unknown person in the Pakistani compound in Abbottabad, is that Osama bin Laden? Sort of any of these questions, and these super forecasters actually apparently did better than the CIA in predicting such events. And he said a few cool things, like everyone would benefit if we could predict the future better. And also mentions that thanks to the frankly quite amazing lack of rigor in medical forecasting, this opportunity is huge. And is sort of, I think, a bit of a wake-up call for us. I'm starting to think that I'm wondering if maybe we are going a little too far in our idea of embracing uncertainty, which is important because a lot is uncertain. And can we do better if we use true super forecasting skills? Of course, communicating these predictions and the associated uncertainty is yet another different skill set. But if we think about this patient, and I'm sure you all have had maybe a patient like this, my young woman with a pontine hemorrhage. And so the family is asking you, what are her chances? And I want to tell you 3 sentences that I have said and that I have taught and that I don't use anymore. And I will tell you why. She will never be the same. I think it's a common sentence, and I don't think it's helpful. Partly for what I said about Paul Kalanithi, who also said that after his lung cancer diagnosis, he wasn't the same anymore. I will say after the birth of my children, I wasn't the same anymore. I just don't think it's a really helpful sentence, and at least shouldn't drive decisions. The second sentence is when we say, we are terrible at prognosticating. It comes from a good intent, because we need to acknowledge that we have been wrong many times and that prognosis is hard after severe acute brain injury. However, we actually aren't that terrible if you compare our skills to that of a lay person, and maybe even Google, which is where they will, or maybe now ChatGPT. I'm not actually sure about how ChatGPT is, but that's where they will turn if we tell them that we're terrible. And if one of us tells them that we're terrible, they will also not trust any of us. And so I'm not sure that's a helpful sentence to say. I think there are other sentences that we can say, for example, that prognostication can be difficult in these cases. And these are the skills that we use for it. These are the tools, and this is how we update it. Nobody expects you to keep saying the same thing over and over. And the third sentence is, I don't have a crystal ball. And that is more like nobody was asking you for one. I think families are actually very realistic when they're asking us what are her chances, and they don't expect you to have a crystal ball. They do hope that you can give them some kind of a roadmap. And I think the best tool that we have these days, I'm not sure it's actually the best, and I think it still needs some work, but the one that we are sort of teaching at the moment is this best case, worst case, most likely case. And it was developed for people to understand their risks for surgery. And so severe stroke is, of course, a very different situation. But I think it's a good idea to start with the best case, worst case, most likely, and inform families that we will update it on the way. And as other things happen, that range will get smaller and might help people make decisions. Amos Tversky, Danny Kahneman's friend, once said, in dealing with probabilities, most people only have 3 settings: gonna happen, not gonna happen, and maybe. So some people might argue, does it really matter how exact we are in our prognostication when in the end it's always a maybe? You know, will this woman wake up again after a pontine hemorrhage? You know, is it a 5% chance? Is it a 65% chance? Or does it matter? Because maybe. The other quote that Phil Tetlock actually said that I think is really important as we make these predictions is that forecasts aren't like lottery tickets that you buy and then file away until the big draw. They are judgments that are based on available information and should be updated in light of changing information. And I think one of the reasons this is important is that I'm not sure about your institutions, but when in our research, when we've done chart reviews, when we've looked back, nobody documents their prognosis. Even in family meetings, we often will document what the family said and what, you know, the patient's wishes might be. But nobody documents what they prognosticated. And I think it's a lot because we worry that we will be wrong. If we change our mindset and say today, because of these facts that we have, this is what I think most best case, worst case, most likely case are. And these are the things that I will be looking for over the next few days or weeks. And that will change the prognosis. And then we can update those. I think it's a bit of a mindset in there. So as we think about managing prognostic uncertainty, I think this anticipatory guidance is really what we need to, is really our responsibility. I like to call it roadmap planning. So providing the family with sort of an idea of what will come next. Have things changed since then? As we consider time-limited trials, I think thinking about, you know, it's sort of a 3-word word. So it's not just giving someone more time, but actually also agreeing on a limit to that time, and acknowledging that it's a trial, so we can see how she fares in the next week or 2. And so maybe sort of as a final thing, just those are the components that we try and do best in. If we can elicit goals and really be a little more certain with prognosis, our hope is that we can get everyone on the same page and provide goal concordant care. And so I will actually end with that because I see I only have 5 minutes left, and maybe open to a little bit of conversation here.
If you have more slides, I think we can go on, but if not, I can open it to discussion.
Well, well, up to you all. I think my slides that were left were where you know, I can just tell you this idea of do these families even have a choice? So our focus tends to be that, you know, we figure out the goals, we figure out prognosis, and then we can get to goal concordant care. We can do shared decision making. And we interviewed families again to sort of better understand their review of the decisions that they made. And it was interesting to see that many people actually didn't even feel that they had made a decision. even though it looked to us as if they had. And that idea is, you gave us uncertainty. And so how could we have made any different decision here? So again, sort of just thinking about how families think a little differently. And then I had slides I had a few pictures of the people that are important to me: Randy Curtis, Will Longstreth, Bob Holloway, who have helped me through this. A lot of what I showed was from my K Award, actually, and a picture of the ICU nurses. So now I've told you about my last slides that I skipped.
All right. If anybody has questions, they can unmute themselves. There's a couple of questions on the chat. The first question, okay, Dr. Ghosh, you have any question?
Hi, I'm Dr. Ghosh, I'm a pediatric neurologist. So I thank you for the great talk. In pediatric neurology, we often end up having to do prognostication for neonates and infants, which is very difficult, especially with the terms of neuroplasticity and with the fact that compared to an adult brain, the neonatal and infant brain is still developing. You haven't really created all, you haven't utilized all of it at this time. And so there's a fair amount of neuroplasticity. Do you have any tips, or how do you address that portion of the conversation as it also pertains to more pediatric or younger patients when it comes to neuroplasticity?
Yeah, I think what you're saying is it is uncertain. And there is even more uncertainty in young patients, and they always surprise us. Time is still extremely helpful, because we do tend to have some kind of a time period in our minds, and depending on the disease, probably also the disease severity, sometimes it's days, sometimes it's weeks, and sometimes it's months. But I think that's where I think our responsibility of roadmap planning comes in, and where it says, right now, the range is a big one that I can realistically imagine that you could face. Over time, I will want her to do X, Y, and Z over the next couple of months so that I can stay optimistic. If I don't see those things, I think my prediction will become a little more pessimistic, and we should meet again and talk about it. And that is, I think pediatricians are actually better at that, although I'm not sure hospitalists, even pediatric hospitalists, aren't. The more I think about it, the more amazed I am at how little we update our prognosis, because we tend to now, residents tend to be on for a month, attendings tend to be only on for a week. And so I sometimes wonder about, we have a weekly stroke management conference where we discuss our difficult cases and how we're going to manage them, or how we should have managed them. We also then talk about prognosis. And so I do think we can do better there.
Thank you.
Johannes, I'm going to let you moderate. Is that okay if you...
Yes, there is some questions in the chat. The first one is from Ahmed Siddiq, one of our residents. He's asking your thoughts regarding mentioning personage from the literature when discussing prognosis with the families.
Yes. That's a great question, because I maybe the best answer is to ask people, but so one of the things that actually so this book by Phil Tetlock about super forecasters, it's really cool, and it's obviously not in medicine, but he actually lists several skills that we should use, and one skill is the outside view, always starting with the outside view. And the example that he gives is, if I ask you to predict whether this beautiful couple in front of you at that lovely wedding is going to stay together, and most of us are going to say, oh, of course, they look so beautiful. How could they ever leave each other? That's the inside view. so you should actually start with the outside view. And the statistics in the US, at least, are pretty shocking. As you all know, 50% of marriages end in divorce. And so that's, I think, where the percentage could help. So with the case that I showed you with the pontine hemorrhage, I actually looked up her ICH score. She had an ICH score of 3, which gave her I actually forget now, but let's just say a 70% chance of mortality after a month. Is that helpful? I think it's helpful for you to think about, just to know it. So start with the outside view. Do you want to give that to the family? I'm not sure. And of course, we all know how the ICH score is biased and all of that. And so to answer your question, I think we should actually use them a little more than I thought we did. I think it can help us frame certain things. I don't think they're helpful for families, and I feel like they tend to hang on to numbers a little too much.
Thank you. Also, for our residents that are here, could you provide any information about fellowship and career opportunities in neuropalliative care?
That's a big one. Good. Yeah, neuropalliative care has become a thing, which is wonderful, which means many different things. It means there are neurologists who are now doing palliative care fellowships and becoming palliative care providers. What this means, just looking at those people across the country, they are going into lots of different things. Some, I would say most of them have found a mixture of practice where they will attend on the palliative care service for a little bit. They will attend on the neurology service for a little bit, and then maybe they sit or they have their own neuropalliative care outpatient clinic. I think that's something really that institutions want to build, that we're building, is neuropalliative care clinics. Again, do you want a neuropalliative care clinic, or do you want the neuropalliative care consultant to sit in one of the ALS clinics, one of the movement disorder clinics? And then I think one thing I think that I'm working on a little more is, palliative care is so much part of what we do. And I don't think we're doing it as well as we could. And so integrating those skills into all of our practice. So we do a serious illness communication workshop, for example, every year during the neurology residency. So our residents get 3 these communication workshops. We're doing a second one now for faculty. So our faculty is doing serious illness communication workshops. And I'm actually not sure I'm really answering your question, but I think neuropalliative care is everywhere. And you should think about, do you want to become a neuropalliative care specialist? There's space for you. And I think there will be more space for you. I do think it's a money question. I don't, I think poor resourced hospitals are less likely to be able to provide that. Should you gain more palliative care skills to become a better neurologist? Yes, to all of us.
Thank you. Anybody, if you have any question, you can unmute or you can type it in the chat.
And then maybe also thinking about fellowship, if you want to do a palliative care fellowship, where should you do it, and should you do it? There's a couple of or 3, I think, places in the US that actually offer neuropalliative care fellowships. We tend to just see it as a track, meaning that a neurology resident who wants to do a palliative care fellowship is actually going mostly with palliative care fellows and just has a continuity clinic with neuropalliative care, which I think is probably what we want to learn most. Palliative care fellowships, they spend time in hospice, they spend time in nursing homes even. And so I think that's still the right focus even for people who want to go into neuropalliative care.
I don't see any questions in the chat. If anybody has any question.
Johannes,
Yes, Dr. Giri. Go
I
ahead.
have a quick question.
Go ahead.
Like you mentioned very correctly, nowadays, attendings are there for a week, 2 weeks, so the continuity is lost. So because of that, they think that having somebody dedicated to palliative care is more helpful in these situations and to be able to help the family.
I think that's a beautiful idea. And if that is the case at your institution, that's wonderful. At our institution, even the palliative care attendings only do a week and then they rotate off. And I think that's unfortunately the reality. Is that different at your institution?
No, even getting a palliative care person to come in, we don't have that luxury as yet. But
yeah.
But again, being a long-time practitioner, I've always, made sure that I have created a rapport with the family. I'm a pediatric neurologist, so again,
I was just going to mention the pediatricians because I know that the pediatricians are much better with this, and I think our pediatric intensivists, they actually have a I forget what they call it, but they a continuity or something. Intensivist. So even if the intensivist rotates off, there's usually maybe one, even not more, family that they have built rapport with, that is a long-termer, maybe in the ICU, and they will keep joining the family meetings. Is that what you do?
Meaning that, that's my personal, approach, because I've found it very helpful that they need to be able to talk with one attending who will see them through. And if I'm in a case, I stay on, even though I have rotated off. And even after they go home, I keep the lines going. And again, I've had the luxury of following many of these families for 30 years and more. So that's given me a wonderful insight. But at the same time, what you mentioned was very good, because we're not good at prognostication. That means I usually start saying, let's take it a day at a time, a week at a time. And then when they're ready to go home, and again, like Dr. Ghosh, my colleague, commented, in the neonatal period, I usually ask them for a year's time. So I said, the baby is the boss, so let's see what the baby is telling us. So I would be able to tell you a lot about what the baby is telling, and so then we can make more decisions. So it's, again, leaving enough room for the families to come to terms and also to say, what do they want? Because acute situation is hard.
Yeah, and helping them look, I think it can be helpful to prepare them to, what we will be looking for if we see them again in a couple months, and what we might be asking them. And so again, peds might be different, but in my stroke clinic, when I see people at usually 2-3 months is when we see people after discharge, they're not prepared for those conversations. And it doesn't sound like they've actually heard that someone would then say, how are you doing? Do you feel your loved one is where you had hoped they would be now? And I think those are conversations that we need to have more and a little more systematically as well.
Absolutely. But I thank you for a wonderful, wonderful lecture.
All right. Thank you, Dr. Creutzfeldt, for taking the time, disturbing your sleep. And it was a very wonderful lecture. Wish you all the best, and hopefully we'll have you back sometime again to give an updated lecture down the line.
Thanks for having me.
All right.
Bye-bye.
Bye, everybody.